Welcome to the deep dive. Today we're tackling a really crucial topic, especially if
Right.
you've got the MSRA exams coming up. Secondary hyperparathyroidism, SHPT.
Hmm.
Now, the key thing, I think, to get straight from the start is that with SHPT, your parathyroid glands aren't just acting up on their own.
No, exactly.
They're responding to something else going on, working overtime, pumping out extra parathyroid hormone. It's secondary for a reason.
Absolutely. And we're diving into this using some really good MSRA revision notes,
Mhm.
the high yield stuff you really need.
Right.
Our goal today is just to break SHPT down, make it clear, make it stick, cover everything, definition, causes, complications, the lot.
Yeah.
Maybe some memory aids too.
Sounds good. Okay, so let's jump right in. What exactly is secondary hyperparathyroidism, the definition?
Okay, simply put, SHPT is when the parathyroid glands make too much PTH. But crucially, it's because of long-term low calcium or maybe a vitamin D deficiency.
So it's a reaction.
It's a compensatory response, yeah.
Yeah.
The body's trying to fix that underlying calcium or vitamin D issue.
Yeah,
It's not a problem with the gland itself initially.
got it. It's like the body's alarm system saying, whoa, calcium's low, crank up the PTH.
Pretty much.
So what usually triggers this? What are the common causes, the etiology?
Well, the big one is chronic kidney disease.
Ah.
CKD. That's probably the most common driver we see.
Okay.
Then you've got conditions causing malabsorption, think celiac disease, Crohn's maybe, where your gut just isn't absorbing calcium or vitamin D properly.
Right.
Vitamin D deficiency itself is a major cause, obviously. Not enough sun, not enough in the diet.
Mm-hmm.
And certain medications can interfere too. Some anticonvulsants, for instance, can mess with calcium or vitamin D metabolism.
So basically anything that throws off that calcium vitamin D balance long term can set this off.
That's the essence of it, yeah.
Okay. So who's most likely to run into this? What are the key risk factors?
Well, age is a factor. It's more common in older individuals. And interestingly, seems to affect women slightly more often.
Huh.
But the big risk factor, as we said, is having chronic kidney disease. That's huge.
Right.
Also, those malabsorption disorders we mentioned. And definitely long-term use of those specific meds that affect calcium or vitamin D.
Okay, clear. So we know the what and the who. Let's get into the how, the pathophysiology, what's actually going on under the hood.
Right. So fundamentally, the parathyroid glands are sensing these chronically low calcium levels or maybe low active vitamin D,
Mm-hmm.
and their response is to grow, that's hyperplasia, and just pump out more and more PTH.
Okay.
And remember what PTH does. Its main goals are to raise serum calcium. It does this by stimulating calcium release from bones.
Pulling it out of storage.
Exactly. Enhancing calcium absorption from the gut indirectly via vitamin D activation.
Okay.
And telling the kidneys to hold on to more calcium while also getting rid of phosphate.
So it's hitting multiple systems to try and bring that calcium back up?
Precisely. It's all part of this intricate dance of calcium and phosphate homeostasis.
Right.
You've got calcium itself, PTH, then calcitriol, that's the active form of vitamin D, 1025 dihydroxyvitamin D3.
Which PTH helps make in the kidneys.
Correct. And calcitriol is key for gut absorption of calcium. Then you also have calcitonin, which kind of opposes PTH. It inhibits the bone breakdown cells, the osteoclasts.
So it lowers calcium?
Yeah, generally. It's a classic
Uh-huh.
feedback loop system. Low calcium triggers PTH. PTH raises calcium. High calcium then normally tells the parathyroids, okay, ease off.
Until something breaks that loop, like CPC or severe vitamin D deficiency.
Exactly. That's when you get into secondary hyperparathyroidism.
Okay, so if we see that high PTH on a blood test, how do we differentiate? How do we know it's secondary and not, say, primary hyperparathyroidism? What are the differentials?
Yeah, a really important distinction, especially for exams. Primary hyperparathyroidism is usually a problem in the gland itself, often a single adenoma, a benign tumor just churning out PTH regardless of calcium levels. So in primary, you typically see high PTH and high calcium.
Got it. High PTH, high calcium primary.
Generally, yes. Whereas in secondary, it's that response mechanism. So you see high PTH, but the calcium is usually low or maybe low normal. It's trying to compensate.
Okay, high PTH, low normal calcium, enters
Yes.
secondary.
That's the classic picture.
Yeah.
Then there's tertiary hyperparathyroidism. This can happen after someone's had secondary for a long, long time.
Right.
The glands become so overstimulated, they sort of go rogue, they become autonomous.
So they just keep pumping out PTH even if you fix the original calcium or vitamin D problem.
Exactly. Even if calcium levels return to normal or even become high, the PTH stays elevated because the glands have changed fundamentally. That's tertiary.
Okay, so that's another possibility. Anything else?
Well, you always have to consider other things that might cause low calcium or vitamin D deficiency that aren't directly leading to SHPT. But yeah, the main ones to distinguish are primary, secondary, and tertiary.
Super helpful breakdown. Now, thinking about the UK, how common is SHPT? What's the epidemiology?
Well, the exact numbers vary quite a bit because it depends so much on the underlying condition.
Right, especially CKD.
Especially CKD, yes. It's very common in people with chronic kidney disease. The prevalence goes up significantly as kidney function gets worse. By the time people are on dialysis, it's extremely common, almost expected, really.
Wow. Okay, so what does it actually look like in a patient? What signs and symptoms should make us think, could this be SHPT?
It can be pretty varied, and often the symptoms are tangled up with whatever's causing it in the first place.
Makes sense.
But some common things you might hear about are bone pain. That's quite frequent.
Just general achiness?
Can be, yeah. Or more localized pain. And over time, this obviously increases the risk of fractures.
Right.
Muscle weakness is another one. And just general fatigue, feeling run down.
Okay.
In more severe, long-standing cases, you might even see things like kidney stones or calcifications forming in soft tissues or blood vessels. But often, you're really looking at the symptoms related to the underlying cause.
Like with CKD, what specific things might point toward SHPT in a CKD patient?
Well, alongside the SHPT symptoms, you might see the classic signs of advanced CKD itself. Things like skin changes, discoloration, easy bruising, terrible itching, that pruritus,
Oh, yeah.
fluid overload signs like edema, maybe crackles in the lungs rails, or even a pericardial rub if it's really severe uremia, nausea, poor concentration, memory issues, all part of the CKD picture that can accompany SHPT.
Okay. And what if it's mainly driven by severe vitamin D deficiency and hypocalcemia? What are the clues then?
Then you're looking more at signs of neuromuscular excitability because of the low calcium.
Ah, okay.
So numbness, tingling paresthesia, especially around the mouth or the fingers and toes, muscle cramps, spasms, even tetany in severe cases.
Right.
And those classic physical signs we learned about, Schwastek's sign.
Tapping the facial nerve.
Yeah, causes a twitch. And Trousseau's sign, inflate the blood pressure cuff. And you get that carpal pedal spasm, the wrist and hand flexing up. In kids, prolonged vitamin D deficiency leads to rickets, those bone deformities. In adults, it might be more subtle muscle weakness, myopathy, or that diffuse bone pain, osteomalacia.
Is that where the memory tip comes in?
Yes.
Oh.
For severe hypocalcemia symptoms, think cats go numb.
Cats go numb.
Yeah. C for convulsions, A for arrhythmias, T for tetany, S for spasms and stridor. And then go numb for the numbness and paresthesia.
Cats go numb. That's brilliant. Easy to remember.
Hopefully.
Okay, what about malabsorption, if that's the root cause?
Then the picture is usually dominated by the GI symptoms of whatever the underlying disease is, Crohn's, celiac, whatever. So abdominal pain, bloating, diarrhea, weight loss. The SHPT is secondary to that.
Right.
And we shouldn't forget simple lack of sunlight, especially in older folks, people who are housebound. That's a common route to vitamin D deficiency driving SHPT.
So key takeaway is symptoms often reflect the underlying cause, CKD, VIT-D defect, etc. Bone pain can feature, but you don't usually get the high calcium symptoms like you might in primary hyperpara.
Exactly. Calcium is usually low or normal in secondary. That's a key difference.
Okay, we suspect it based on the clinical picture. How do we actually confirm the diagnosis? What are the essential investigations?
It really comes down to the lab test. Number one, you absolutely need a serum calcium level.
Okay.
And critically, you should measure the intact parathyroid hormone, the PTH level, at the same time as the calcium, drawn together.
Why at the same time?
Because you need to interpret them together. Is the PTH high because the calcium is low, secondary? Or is the PTH high despite high calcium, primary? So same samples, best practice.
Got it. Calcium and PTH together. What level of calcium is considered low?
Generally, below about 2.1 millinel would indicate hypocalcemia.
And the PTH. What confirms hyperparathyroidism?
The PTH level itself is the definitive test for hyperparathyroidism. A level consistently above the upper limit of normal, which is often around 88 nanograms per liter, depending on the lab assay, confirms it.
Okay, calcium, PTH, what else?
Serum creatinine is vital. You need to assess kidney function, usually calculated eGFR. And eGFR below 60 suggests CKD might be playing a role.
Right.
And of course, you need to measure 25-hydroxyvitamin D. That's the main storage form. Tells you about vitamin D status.
Yeah.
Levels below 75 nanomolar are generally considered insufficient. Some labs use slightly different cutoffs, but that's a common one.
Makes sense. Any role for imaging initially?
Not usually for the initial diagnosis of SHPT itself. Imaging like ultrasound of the neck, maybe CT, MRI, or the sesame nuclear medicine scans,
Yeah.
they come in after the diagnosis, mostly if surgery is being considered, for example, in tertiary hyperparathyroidism or severe primary, to locate overactive glands or hyperplasia.
Okay, so primarily labs first, and what's
Mhm.
the typical pattern we expect in SHPT labs?
The classic finding is low or low normal calcium with an elevated PTH.
Right.
Phosphate is variable. It's often high in CKD because the kidneys can't excrete it properly.
Okay.
But it might be low or normal in pure vitamin D deficiency or malabsorption because PTH actually promotes phosphate excretion by the kidneys.
Ah, interesting distinction.
Yeah. And radiology, if done later, might show signs of bone disease like thinning bones, sometimes specific changes called osteitis fibrosa cystica in severe cases, or those vascular or soft tissue calcifications, especially in CKD patients.
Okay, so we've got the diagnosis nailed down. What's the game plan? How do we manage SHPT?
Right. Management has two main aims. One,
Mm-hmm.
treat the underlying condition. That's paramount.
Fix the root cause.
Fix the root cause if you can. Two, directly manage the calcium, phosphate, and PTH levels. Correct those imbalances.
Okay. And how does that look in practice? Does it vary a lot?
It varies hugely based on the cause, and especially with CKD, it depends heavily on the stage of kidney disease.
Right, so let's break it down. What about earlier CKD, say stage 3 or 4? PTH might be moderately up, maybe 70 to 300 NGL.
Okay, for CKD 3 or 4, the first step is often dietary phosphate restriction. See if that helps.
Makes sense. Kidneys aren't clearing it well.
Exactly. If diet isn't enough to control the phosphate or the PTH is still climbing, then you'd usually start a phosphate binder. Things like sevelamer, lanthanum, those are non-calcium based, or calcium acetate, which is calcium based.
Yeah.
Then you look at vitamin D. If their 25-hydroxy vitamin D is low, you give them a supplement, usually ergocalciferol, to replete their stores.
Standard vitamin D replacement.
Right. But if their storage vitamin D is okay, but PTH is still high, you might consider using an active vitamin D analog,
Like calcitriol.
like calcitriol, or others like doxorcalciferol or paracalcitol. These bypass the kidney activation step and directly suppress PTH. But you have to watch calcium and phosphate levels carefully with these, as they can increase absorption.
Okay. What if the patient is hypercalcemic already? You wouldn't use calcium acetate then.
Good point. No, if they're hypercalcemic, you definitely favor a non-calcium-based binder like sevelamer or lanthanum.
And if they're hypocalcemic?
Then a calcium-based binder like calcium acetate, or even additional calcium supplements like calcium carbonate or gluconate might be needed.
Got it. What about more advanced CKD stage 5? Dialysis patients, PTH, often much higher, say 300 to 800, maybe more.
Yeah, here the PTH levels are often much harder to control. Active vitamin D sterols like calcitriol are often first line.
Still using those.
Yes, but often you need more. Doxorcalciferol or paracalcitol might be tried as second-line vitamin D options. And this is where calcimimetics often come in.
Cinecalcit.
Cinecalcit is the main one, yeah. It essentially tricks the parathyroid gland into thinking calcium levels are higher than they are.
How does it do that?
It increases the sensitivity of the calcium-sensing receptor on the gland. So even with lower calcium, the gland gets the signal to reduce PTH production.
Clever.
It is. It's an important tool for managing high PTH in dialysis patients. Adalcalcitide is another intravenous calcimetic option, sometimes used second line.
Okay. Now, switching gears slightly. What if the SHPT is just due to lack of sunlight? Simple vitamin D deficiency.
Much simpler management, usually. First line is just vitamin D supplementation, ergocalciferol typically, and maybe some calcium carbonate initially, especially if they're quite low, to support calcium levels as the vitamin D is repleted.
And for malabsorption-related SHPT?
The absolute key there is optimizing the treatment of the underlying gut condition. Treat the Crohn's, manage the celiac disease strictly with diet.
Right.
Then you supplement vitamin D and calcium as needed based on their levels, just like with dietary deficiency.
Okay, that covers prescribing. What about non-drug approaches?
Well, for CKD34, as we mentioned, dietary phosphate restriction is the first-line non-prescribing step.
Right.
For lack of sunlight, the non-drug approach is, well, sunlight, sensible sun exposure, 5 to 15 minutes on exposed skin, avoiding peak burning hours can make a big difference for vitamin D production.
Good advice. Any non-drug options for severe CKD stage 5?
Yes. If PTH is really high, say consistently over 800 NGL, and it's refractory, meaning it's not responding well to maximum medical therapy, then surgery is considered.
Parathyroidectomy?
Yes, either a subtotal parathyroidectomy, where they remove most but leave a small piece, or a total parathyroidectomy, where they remove all 4 glands and sometimes autotransplant a small piece, often into the forearm muscle.
Why put it in the forearm?
Easier access later if that tissue becomes overactive again. Easier to remove than digging around in the neck a second time.
Ah, makes sense. So surgery is reserved for severe refractory cases in CKD.
Pretty much, yes. Medical management is always the primary approach. Address the cause, correct vitamin D, use binders, vitamin D analogs, calcimimetics, escalate as needed. Cinacalcid is key for a refractory SHPT in end-stage disease if surgery isn't suitable.
And you mentioned early intervention in CKD 3 and 4.
Yeah, studies suggest that getting on top of rising PTH early in CKD can help prevent bone disease, maybe cardiovascular complications, and potentially improve survival. So monitoring and intervening appropriately is important.
Okay. And the surgery, if needed, is it always curative?
It's usually very effective, but there's about a 10% risk of the hyperparathyroidism, either persisting immediately after surgery or recurring later on.
Good to know. So overall, what's the long-term outlook, the prognosis for SHPT?
It really hinges on that underlying cause and how well it's managed. If you can effectively treat the CKD or correct the vitamin D deficiency or manage the malabsorption, then the prognosis regarding the SHPT itself is generally good. Symptoms improve, complication risk drops.
So treat the cause, manage the levels, and the outlook is decent.
Decent, yes, but requires ongoing monitoring and management, especially in CKD.
Right. And what happens if it's not managed well? What are the potential complications we're trying to avoid?
Several serious ones. The constant PTH drive pulling calcium from bones leads to osteoporosis and a much higher risk of fractures.
Okay.
In CKD specifically, it contributes to that complex bone disease, renal osteodystrophy.
Right.
There's also a significant link between SHPT and cardiovascular disease. Those calcifications we mentioned can happen in blood vessels, increasing stiffness, and cardiovascular risk.
Not good.
Not good at all. And ultimately, poorly controlled SHPT, especially in advanced CKD, is associated with increased mortality risk.
So definitely something we need to diagnose and manage effectively. Okay, so let's quickly recap. Secondary hyperparathyroidism, it's the parathyroid glands working overtime, but as a reaction to low calcium or vitamin D, often due to CKD, deficiency, or malabsorption.
Spot on.
Finding and treating that underlying cause is number one. Then management involves balancing calcium, phosphate, vitamin D, and PTH using diet, binders, vitamin D forms, calcimimetics, and occasionally surgery.
You've got it. Understanding its secondary, the compensatory mechanism, is key.
It really highlights how the body tries to keep things in balance, doesn't it? But sometimes that very attempt to compensate can lead to its own set of problems down the line.
It's a fascinating and clinically very important example of that interconnectedness, definitely. Makes you think about those feedback loops and what happens when they're chronically stressed.
Absolutely. Well, that was a fantastic deep dive. And for anyone listening who wants to reinforce this and other key topics for the MSRA, definitely check out pastthemsra.com.
And freemasray.com has some great free resources, too.
Excellent. Thanks for joining us.